So today they asked me to talk about current and future directions in nursing education and practice, some of the things that will change the way we teach and change the things that we need to teach as nurse educators. So first of all, I always like to acknowledge where I come from Swinburne University and from the lands of the Wurundjeri people of the Kulin Nation. They're the traditional owners of the land for many, many years. And we always pay respect and acknowledge their elders, their past, their current, and their emerging new leaders as well. And also thanks to the University of Parma for hosting me here and for the support of Antonio Bonasara and others in the team like yourselves that have made this visit possible. Yeah, now I need to go back. So I was born in New Zealand and I also gained Australian citizenship though. So I'm both a Kiwi and an Aussie. And those are our icons, our kangaroo and our Kiwi. And I'm a New Zealand qualified nurse and midwife that's always been very committed to keeping learning for life really. I've worked, taught and researched nationally and internationally in health education, social services across a range of public service departments in Australia, New Zealand, Middle East, Africa, Asia and the UK. And I'm now a professor of nursing, but also health workforce development. I look at things across the whole health workforce. And I like to engage in capacity building and partnership-based activities like we're doing here. Out of interest there, if you want to know how big Australia is, I think it's the second or the first largest continent on the planet, and that is Europe. And you will see Italy there. It fits inside of all Australia. Australia is very big, but the middle is a big desert and a lot of rocks. Yeah. Yeah. Okay. Oops, it's going the wrong way. There's this thing that's, look at that. So today we're going to talk about various trends in nursing education and practice. And about, first of all, before you can even talk about the trends, the issue of clinical currency for educators. How do you keep yourselves up to date? And how do you know where practice is heading if you haven't been anywhere near practice for a very long time? And then I've got some examples of current directions of nursing education practice and health service delivery, interprofessional education and care, expanded roles for nursing, and telehealth and virtual care. It's a magic just where you, yeah. So maintaining clinical currency, it's a crucial aspect of your nursing education and practice. And it's difficult and it's challenging because you are very busy. You are teaching, you are writing, you're researching. How do you stay connected? And I keep not pressing the right place for this. So it's really important that the content that's studied in the classroom, what you're going to teach your students, should match and correlate what they experience in the ward and future trends. And quite often there's a theory, the education classroom and the practice gap. That's really commonly encountered, and it's a topic that's been debated for 50, 100 years, right? And that if that gap exists, efforts should be made to try and reduce that. And that is part of the partnership that is really important between the university and the hospital, or practice, theory and practice. And you have to know where that gap is, and you have to know where things are heading, because you can't teach about the future trends if you don't know what's happening in practice. If you don't know, how can you teach about those trends, basically? to be able to know requires that you have first-hand knowledge of what's happening in practice. So sometimes you have an educator, and it can happen in my country too, that it is 10 years since they stepped foot in the hospital. So how do they know? They haven't been present on a shift. They aren't talking regularly with the educators. Now, one of the benefits of this university is that a lot of your teachers are over in the hospital. And so that link is very important. And the practice should inform your theoretical input to what you're teaching. You must be clinically connected to be credible. If you are disconnected from your profession, it's hard to stay credible. Yeah. And when you look at a whole lot of the studies, that the academics who engaged in clinical practice reported that by doing so, they gained insight into the current clinical, cultural, and technical issues of contemporary practice, and then that influenced their teaching. What you see in practice influences what you teach. The benefits of the clinical connections, it makes you academically credible. And a lot of universities are now expecting the faculty to demonstrate how they relate to the clinical environment. Increasingly in universities, that's a competency that you have to be able to show. And you need to prepare students for clinical settings in which rapid changes are occurring. So if you're not up to date with the rapid changes, it's very hard to teach your students well. Yeah, and the students, if they are taught and if there's a good match and no gap, the students report that they're more happy with the teachers. They respect teachers who they think are connected and up to date. It's also, the other thing is that it's a very rich source of research, you know, because if you're going to research, you want to do research that's translational research, that's really current and relevant. And it's relevant if you know and you are connected. So the benefits for the faculty is that the academics gain valuable experience, which can inform the teaching. It helps them bring the clinical anecdotes. So when you tell stories about working with families, it's better than a textbook. So if you can tell real stories about what happens in practice, then students are more likely to listen, because it is the stories of practice and the stories of real care that actually students may remember that, rather than just going through pages of a textbook. Yeah. And reality and stresses of clinical work cannot be fully appreciated that if you're not clinically involved. And also being visible in the clinical areas allows academics to keep abreast of the political climate, right? So it also helps you with the politics of the, rather than them and us, you all being part of the one team. And the benefits for the clinical area, academics can be viewed with skepticism by the clinical nurses, thinking they've lost touch with the reality of practice and that they're out of date. But if academics are visible and accessible, they help improve the relationships. And in time, the hospital starts to, and the hospital nurses and the community nurses and the nurses in practice start to really gain respect, and they will ask about, what do you think about this idea, and what have you been teaching about that? So you get that exchange going on, yeah. And then the nurse academics will be well positioned to understand and teach about future trends. So like, before you can even start a conversation about what the future trends are, if you're sitting in a little box at a university or by yourself and you're isolated, it's very, very hard for you to know. You can read, you can watch YouTubes, you can do things, but it's not the same as actually going to clinical practice from time to time. So there's some really big things that are happening in healthcare, and some of those are there. First of all, a lot of the trends are global, and movement of nurses in particular, but doctors too, is a lot of global movement. People migrate, they change, they shift, and a lot of the issues are, rather than just a country's health workforce or trends, they're global trends. There's also a lot more focus on the individual, you know, like patient-centered care. So actually individualizing rather than same for everybody, actually looking at the individual needs. There's a lot of digital technologies and things coming in. And there's also a need to be a lot more inclusive so that the care that's provided is inclusive of families and communities, and also inclusive as part of teams. So some of the things that are actually happening in that is the ageing populations, and these are global issues. So people are living longer due to very medical advances. They are living longer, but they're not necessarily living better, right? Yeah. Yeah. Everybody's having fewer children, okay? So global population is actually starting to decline. And they've declined in almost every country in the world since 1970, except for Africa, right? By 2040, one in four, 25% of the global population will be African.
So, in just a fact, how many child?
So like when in my era when I was born, there was a kind of saying in terms of people would usually have one for mum, one for dad, and one for the country. You know, because the country needed more workers, and you needed more people on the fields, and you needed more people on the farms, and you didn't have social security and pensions, so you needed children to run the farms and do the work and look after you when you were old, and you also had one or two spare in case one died in infancy, right? But as countries have become more educated, there's a few things that are happening. First of all, white people are becoming extinct, right? So that something like, I think I saw the figures by 2040, 2050, 3% of the world population will be white, 3%, okay? Yeah, so the countries that are having children are Africa. So when I was in Uganda, there's 66 million people. This was 3-4 years ago. They were increasing their population rate by 3 a minute, 1 every 22 seconds. Their population was growing. The average birth rate for a woman was still 6 to 7 for every woman, right? In countries like here, like Italy, your reproduction rate now is 0.8 or 1.1. So to maintain your population, you need 2. One couple needs to have 2. So also the demographics in terms of parts of India, not so much the educated parts of India, they're coming back to 2 people only, right? Parts of the Arab world, and Africa. Africa is the biggest growth rate globally. But most other countries, the population has declined since the 1970s. So that means less younger people, not enough babies, so you get more older people. And the more older people also, because we're getting very clever at helping people live longer. Yes, yeah. So the social and economic impacts of that the demand for healthcare, social services and pensions are growing, right? But there's fewer and fewer young people to earn the wages to pay the taxes for that. So that becomes a big squeeze, right? There's workforce shortages because there's not so many young people. So you have lots of old people needing healthcare and social services and not so many young people. And so that's why we have nursing workforces shortages, and shortages of builders, and shortages of plumbers, and shortages of all kinds of people. And the health issues, chronic diseases, not only are people getting older, but the chronic disease is increasingly common, and it requires intensive resource and support, because the people who are older are not necessarily living better, and some of the people who are younger are sometimes not looking after their health. Yeah. So a major challenge is the health and nursing workforce shortages. Estimated 29 million nurses worldwide and 2.2 million midwives. WHO estimates a shortage of 4.5 million nurses and 250,000 midwives by the year 2030. Right, so that is not just so much that people are not choosing to be nurses, is that there's not so many young people to choose to be nurses in the first place. Yeah. So by 2030, a total of 4.8 million nurses and midwives, with the greatest shortages found in Africa, Southeast Asia, and the WAH Mediterranean regions. And one of the reasons for that is that whilst they're having more babies, a lot of their nurses are migrating to other countries. And so that leaves a shortage in their own country. Then there's the issue of chronic disease. They rank now as the leading causes of death worldwide. And pre-existing chronic disease such as heart disease, diabetes, cancer, and associated risk factors such as smoking and physical inactivity increased the risk of severe COVID. So basically, then if people weren't so fit and well and they had chronic disease when COVID came, they were more likely to die because they weren't in good shape and weren't in good condition. Yeah. The global cost of chronic disease is estimated to be 47 trillion by 2030. And one of the key things is junk food is killing us. It is good. I have not seen McDonald's here. no McDonald's in Parma. I haven't seen one. It's not necessarily the drugs, the alcohol, the cigarettes, or the shisha. All of that stuff's not good, but it's the food, highly processed junk food, and the lack of exercise is the greatest threats to public health globally. I worked in the UAE, and young men and women and young men in the UAE are having heart attacks and coronary vascular disease 20 years younger than the global average, because they have a very rich and affluent lifestyle, and they drive around in cars, they don't do much exercise, and so those things are happening to them quite early. And there's your chronic disease. Once you have a chronic disease, and many people, once they hit 50, have got 2 or 3 or more, right? It's a long journey which care and support needs to be designed and best supported and optimised to enable a full life. But that's very expensive and requires a lot of support. Yeah. But many of the chronic diseases are preventable, and risk can be modified by particularly 4 factors: physical activity, nutrition, tobacco use, and alcohol. If those 4 things were pared back, there'd be quite a lot of reduction in chronic disease. But and you'll often find that the social and behavioural change that's needed and the non-medical factors and social determinants get in the way. So, for example, when you look at the African cities, the people were nomadic, highly active, ran a lot, didn't have cars, etc. But increasingly, to have work, they come into the cities. Once they get in the cities, their traditional foods, they don't have access to it. And so they buy what is cheap. So the cheapest food is the white bread, the white rice, all of the foods that then contribute. And in a funny sort of ways, their body is not used to all that food, and obesity and chronic disease very quickly become significant problems. Plus, there's the whole thing about what our kids are doing and not doing. Yes. What's that? Yes. Yeah. Yes, that's right. Yeah. But I like that I walk here every day and walk back, and then 4 times in a day I have to keep walking over to that other building on the other side of the campus. It is all very, very good. Yes. So but the thing is that it is an effort as an adult, but this is what's happening to children right from a lifetime age, etc. So it's some of what we do does not create a better future for us. Yeah. So how can nurses help with all of that? What can nurses do? And what is our role? What do we got? What is it about us? Okay. So there's new and emerging models of primary led healthcare. Nurses and midwives are the backbone. 23 coming up 29 million globally, right? 50% of the health workforce are nurses, right? And countries are increasingly looking to nurses, midwives, and allied health professionals to provide prevention and disease management in response to the burden of chronic disease, right? And better utilisation of the nursing workforce is a strategy being used by governments to strengthen healthcare systems, allowing nurses and midwives to work to the full extent of their scope of practice, rather than, no, a nurse can't do that, and a nurse can't do that. You know, you can't. And my view about it is that doctors are a very important part of the health workforce, but they have longer training, they have more specialist skills, they are more expensive. There are big waiting lists out there of people to be seen, that the doctors do the specialist stuff and let them devolve and allocate to nurses. I keep saying there is more than enough work for everyone. There is plenty of work for everybody. We don't need to fight about the boundaries. Yeah.
Actually,
Yes.
we have a lot of doctors,
Yes.
but they don't want to work in hospital.
Yes. Yeah.
Because they want to get much money.
Yes.
So
Yes.
they prefer to work in the
Private.
nursing, yeah, the private. So it is one
Yes.
of the important point that we have to
to think about. Yes. Yeah. In Australia and New Zealand, many doctors work in private practice, but they also work in public, right? And the reason they work in public is that they are part of teaching medical students, and it helps them with their medical credibility. Because if they work in private practice only and they stay away from the teaching, they get out of date, right? So it's a very important thing in our countries around credibility. They do both. Yeah. Yes. Yeah. Yeah. Yes. The private practice earns them lots of money, right? The public practice helps with their research, their clinical skills, and preparing the next generation, and their credible and their clinical credibility. Yeah. So nurses and midwives everywhere have taken up the challenge of leadership, sometimes with strong government and government support, and sometimes with little or no support. There are still some countries that are still trying to fight it. So I worked in and out of Pakistan a lot. It's a very unusual country. In Pakistan, it's the only place I went to. They graduate more doctors and nurses in Pakistan. I've never seen it anywhere else. Okay. And so the nurse is still very suppressed. Yeah. And they graduate more doctors.
So we get some doctors.
Yes. Yes. Yes.
We done before.
Yes. Yes. Yeah. So advanced practice from nursing roles, that's becoming more and more common. So in many countries, there's a registered nurse, an RN1, and then you can have specialty and advanced practice. And those roles include, but are not limited, allowing nurses to do patient counselling and health education, physiological and psychological assessment, screen patients for disease risk, order basic diagnostic tests. Like if you see a patient and you suspect that they might have type 2 diabetes, or that they might be anemic, it shouldn't really need a doctor to prescribe that test. A nurse should be able to prescribe that test. It's pretty basic, you know. So prescribe and deliver treatment services. And so, for example, a physiotherapist in our countries can prescribe an activity plan and the various things that need to go with it. You don't need to go to a specialist rehab doctor to do that. Admit or discharge patients from their caseloads and refer patients to other health agencies, education, training, service improvement, research and evaluation, and work in partnership with medical specialists and multidisciplinary teams. And nurse prescribing is also becoming increasingly common, as is pharmacy prescribing. You know, pharmacists, you can go to the chemist shop and they can prescribe things in our country. And if I need vaccinations, I don't need to go to the doctor, I just go to the pharmacist that can. Paracetamol, you just buy off the shelf.
Yeah, sure.
Yeah. So contraceptives.
All right.
Uh,
Vitamin integrators, something like that.
yeah, basic antihypertensives, all the basic drugs. Yeah, yeah. Iron supplementation, if you've done a test, etc. Yes, yeah, 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 yeah. So advanced practice, and RN meets those competencies. In advanced nursing practice, it's a higher capability that's recognisable and requires further training and an additional licensure. Right? Advanced practice, clinically based practice, it's got to be safe and effective, a research-based education. It's advanced practice is not necessarily a role, it is the level of practice that you're allowed to do. A role is a nurse practitioner, right? So nurse practitioner. Yeah. So these are the ways that nurses are helping the situation. Yeah. So nurses and universal healthcare. So in 2018, I had the privilege of working with Sir Nigel Crisp and the World Innovation for Health, and we wrote a report highlighting the way that universal healthcare, which universal healthcare simply means that everybody can access the care that they need, so the report is about nurses and midwives being the key and the answer to expanding universal healthcare. And it's vital to concentrate on health promotion and prevention of the disease, because if you can prevent a lot, and if you've got nurses doing a lot of primary care prevention, you don't see those children in front of computers all day. You don't see children eating. If the public is more aware of what it will do to health. So a lot of roles in health promotion and health prevention. And nurses and midwives are best placed to combat those non-communicable diseases and lifestyle changes. And nurses in advanced roles can be the vanguard or the leaders in cost-effective expansion of services. Then there's nurses in primary care, and again, I've put 2 books that I was part of, the lead author and one and the last author on the other, in terms of the role of nurses and midwives in East Africa and nurses and midwives in Zanzibar. And you can Google and you can see these books online if you want to have a look at them. And then nurses and empowering women. So in the last 2 days, you've been having proclamations here and graduations of your nurses, right? And those nurses, quite a few of them are first in family, right? So particularly, we did a study in Tanzania that basically looked in detail of the impact of nursing education on family socioeconomic status, on children being able to go to school. And by educating a woman as a nurse, she helped look after the health of her family, her community, plus she had income that allowed her kids to go to school. So nursing, basically then that becomes a method by graduating more nurses of intergenerational empowerment and more families not so socially economically dependent. So it was a study that we did, again, in one of the countries, about the power of what nursing can do. So also, if you really want, like, how do you get these things to work, right? How do you get so that that future can change? It actually requires the collaboration, the partnership and the cooperation of the nursing regulation, that's Nursing Council, the rules of the country, the academics at education and those in practice. You've got to align those things. So you have to have the enabling legislation. It's got to be possible rather than illegal, right? You've got to have approved scopes of practice, whereas the Nursing Council can say in discussion with education and practice, this is what an RN should do, this is what a nurse practitioner can do, this is what it means, right? Advanced and especially higher education programs, you have to actually have a program. The universities in partnership with practice needs to do the qualification to be able to get there, and clearer understanding of the definitions and kind of less boundary protection. Still got to have safe practice and keep the public safe, but it's actually allowing better use of your nursing and midwifery workforce. So, you know, nursing education goes everything from the second tier nursing assistants to the bachelors, to the postgrad diplomas, to the masters and PhD. You need that structure. You've got that structure, right? Practice, you've got a beginning practitioner, competent practitioner. For nurses, not so much yet in terms of specialist or nurse practitioners. They're not there yet, right? But to get there, you have to have the nursing regulator and the governing bodies have got to put that in place. So in many ways, the university's poised and ready, but you need the changes with your nursing regulation to be able to get there. That's what it takes. It then becomes a system that enables nurses to help in the reality of the situation. And it is rapid future trends in many countries of the world that this is, that the nursing regulation and governance is allowing this.
Improvement of responsibility as well. It's ready to the road.
Yes, yes. So when it's possible, what do you see? How is nursing actually contributing? So caring for the chronically ill currently consumes 75% of the nation's healthcare resources. I recently looked at some figures and some statistics from Tasmania, which is an island just off the bottom of Australia. They're spending 85% of their total healthcare budget on people in the last 2 years of their life. And it's probably much the same here. So when you think about, you know, prevention, vaccinations, primary care, pregnancy, birth, but then if you go to the hospital and see what it's full of, older people with all the chronic diseases, the cancers, the things. So many countries are spending even up to 90% of their entire health spend on people in the last 2 years of their life. That dial needs to shift, right? Yeah. So there's things like nurse-led clinics, and I've helped set some of these up. A clinic where the nurse has his or own patient caseloads and an increased autonomy of the nursing role with the ability to admit and discharge patients from the clinic and refer on to more appropriate healthcare. Right? So we ran a pre-diabetes clinic where people would come in from the community, often referred by to their GP, and they would be there for 3 or 6 months, and they would be taught and worked through the behavioural and social changes they needed to improve their lifestyle, if that was under control. So there's the things that nurses, nurses assume their own caseloads. They provide an educative role to patients and provide psychological support, monitor, and they have expanded roles within the clinics usually, and they have scope of practice, which is usually defined by their state, provincial or territorial government in partnership with their regulatory body. Okay, so that is an increasing global trend. Right. Huh. Why have I got this?
Sorry, not is close to GP or not?
Yes,
Yeah.
yes, and looks after a lot of routine things.
So it's very
Routine, yes, yeah. But you can get a nurse practitioner in mental health, or a nurse practitioner in endocrinology, or which is a lot to do with the diabetes. So they also often specialise. So why did that tell me? Why will that suddenly not go to the next slide? So, it said it was not. It said it was not connected. I don't know. I don't have the right touch. Yes, yeah. So why? What is the rationale? What's the purpose for these nurse-led services and advanced practice roles? It goes back to what we were talking about earlier. growing burden of chronic disease. So that's hugely increased general practice and medical specialty workloads, right? There's not enough of them. There's too many people. It's like a tsunami wave coming through, right? Australian and international evidence tells us that effective chronic disease prevention and management requires systems, that are chronic disease registers, patients' follow-ups, recall and review mechanisms and patient information systems. It's not about just going to the doctor once and oops, you've got a bit of a pneumonia, have an antibiotic, you're right. It's all of this stuff, right? Education and support, patient information, patient education, community linkage, connection to the community to try and have a walking program, healthy eating courses, all those kind of things, effective teamwork. And it's also really the need for links between the medical specialists, nurses, and other members of the healthcare team. And integrative collaborative services, left out a word there, relieves medical practitioner workload, increases services to patient, and improves patient outcomes. It's not a threat to the medical profession. There is more than enough work for everybody. They are overwhelmed with the amount of work, right? Some early studies show reduced hospital presentations when general practitioners include nurse-led services within their practice. So my GP back in New Zealand, they have 2 nurse practitioners, and you make up your mind as to whether or not you think you need to see the doctor. Mostly you can just go and see the nurse, right? But if the nurse detects something that the doctor needs, she'll make you an appointment to the doctor. But then there's not you don't have to wait so long to see the doctor. Yeah. And many things are things that the nurse can do. Like, for example, my grandson goes jiu-jitsu fighting, right? Mm-hmm. And he's got a brown belt or something now, right? So there's a mat and there's these things that they wear, that get washed sometimes, but not every training they get hung on the hook. Lots of sweat, right? Lots of rubbing of his sweat on the other person's sweat, right? So he gets a couple of little scratches on his neck, right? And then he gets a staphylococcal infection, not streptococcal, staphylococcal, okay? So boom, it starts spreading, okay? Highly infectious, all right? A bit like conjunctivitis, like boom, staphylococcal, right? He needs flucloxacillin. He needs to wash all the things he's doing until it's better, no more jiu-jitsu, okay, right? So he goes to the nurse practitioner who takes a swab that confirms it, who gives the flucloxacillin. Yeah, no problem. Why does he need to see the doctor? The answer is obvious. I know it, you know it. This is nurse within nursing knowledge, right?
You take some which
kind of antibiotics, flucloxacillin, yeah. So if it's streptococcal, like the sore throat, which can lead to rheumatic fever, you're looking at the penicillins, right? But if it's staphylococcal and an anaerobic bug, you need flucloxacillin or something like that. So nurse practitioner can do that. You don't have to bug the doctor, right? So those are the kind of nurse prescribing and the kind of things that happen. Yeah. So the other thing that's really important is the issue then of interprofessional education and practice. So I was running a clinic like this in New Zealand, if you have pre-diabetes, right, with the right social and behavioural change, that can be halted and not progress to type 2 diabetes. You can stop it. And you can detect it, say the doctor might detect it from a borderline fasting blood sugar. Okay, not quite type 2 diabetes, but a bit higher than it should be. Okay, stand on the scales, waist circumference a bit much, BMI not quite what it should be, smoking, like kind of, and likes to have 3 beers every evening. Okay, not heading in the right direction. No. Age 40, right? So the old system where the doctor would say, come back in 3 months and I will do your blood sugar again. And you go away and you be good, stop the beers, do some more exercise. And it's this linear thing where you go to the doctor, you come back, 3 months later. What happens 3 months for 90% of the people? They might put on 2 more kilos, they're still smoking, they haven't done it, So interprofessional team, you now basically need programs of care rather than linear visits with the doctor, okay? So the doctor's part in that is to every quarter see the patient for total assessment, medication review, but in between, you have interprofessional practice where, say, I was running a student-led clinic, right? So you have the nurse, which is like the diabetic nurse, the occupational therapist, what's their lifestyle like, the physiotherapist and the exercise physiologist, and the nutritionist, the dietitian, okay? So over a 12-week period between that doctor's visit and that doctor's visit, they have a program. They come in, they do an activity, a physical exercise program. They can come every week and get weighed. They can get physically active. They can have classes about how much cream and butter and cheese they're putting in their food, how to make it more healthy, and some help if they have if they are addicted to beer and addicted to, right? Primary care clinics run by nurses and midwives and others, interprofessional clinics, team clinics, all right? And then as they're going, they keep watching their HB1AC, etc. And then they send notes back to the doctor. So the doctor knows what's going on, right? And the doctor sees them every 3 months. So to effectively manage these conditions requires interprofessional practice and programs of care, rather than the doctor takes the blood sugar, says, behave your life, come back in 3 months. And then this goes on for 4 visits in a year. Oops, you better have some metformin now because now you're type 2 diabetic, So these are the kind of team-based programs and how health service delivery is changing. Yeah? So this was one, and you can read about it, is a clinic that we put in the Rockhampton in Queensland, right? And there's publications and there's a toolkit about how to set up the clinic, what you need to do, etc. And the GPs used to refer to us all of the patients that they were getting frustrated with, right? All of the people that kept coming back time and time again and nothing had changed, right? To come to the clinic, and we had a podiatrist, because a lot of them were diabetic, so they had diabetic foot and ulcers, all right? A nutritionist, right? An exercise physiologist, students under the supervision of one professional running the clinics. And we got amazing results, amazing. Some people who had had up to 8 hospital admissions in a year had no hospital admission in 2 years, yeah? Because you could keep them well, keep them out of hospital, start to change practice. Now, a GP does not have the time to do all that. A GP says someone, then says next. GP says someone, then says next. This is how the team works together.
How many people GP look after? How many people?
A GP, on a GP practice, usually 2,000 to 3,000 on the base.
It is 1,000.
Yeah.
1,000.
Yeah. And the wait list to get in the GP are getting longer and longer, which is why you're now saying, what does the GP need to do and what can others help with, right? So this is another example of a multidisciplinary team. And again, there's about 4 publications about collaborative task sharing to enhance what's POCUS, point of care ultrasound access amongst expected women in Kenya, the role of midwife. So I interacted in this project in my role as a midwife in Kenya between 2015 and 2019. I did this project, and I'll tell you about the project. So this was the challenge. less than 1% of women in Kenya in their pregnancies have an ultrasound in pregnancy, right? And it's usually the more affluent that are in the big cities. But all the women in rural areas, no ultrasound in pregnancy. Therefore, if they turn up for delivery and they've got a stage 4 placenta previa, you know what a placenta previa is, where the placenta's over the vaginal canal, right? You don't know that until the woman starts bleeding and they're in labour and you've got either a dead baby and mother or both. If you have a fetal abnormality, you don't know that, right? If you have twins or triplets, you may or may not know that. If you have a breech presentation with the baby coming with the wrong way, you will not know that necessarily. They just turn up, right? So many lives can be lost. And there is a saying in Africa, to be pregnant in Africa is to have one foot in the grave, right? So the issue was, how do you increase point of care, that is where the woman is ultrasound services for more women in Kenya, okay? So one of the things we would think about, well, we need to build more ultrasound clinics and we need to train those ultrasonographers, okay? Very expensive, 10, 20 years, that ain't gonna happen. Like, it's just not gonna happen, okay? So this was a partnership of the solution. The head of radiology at the Aga Khan University Hospital, so he's a specialist radiologist, right? With his sonographers, people who can read ultrasounds, an obstetrician, a specialist obstetrician, and me as a midwife, okay? Team, okay? So what we decided to do was, if we wanted to take ultrasonography out into the African countryside, what technology would we want and what workforce would we want, right? So the workforce, we thought about, if you want to teach someone to do ultrasounds, right? And we want them to just, not the whole body, you don't want to teach them everything, you just want the female reproductive thing and a pregnancy, that's it. Who knows the most about anatomy and physiology of women's, and who's got the most existing knowledge that you could teach them the quickest? It's midwives, right? They already know a lot about that, okay? You just need to teach them how to do an ultrasound thing and to read it, right? So we trained midwives with the competencies to provide point-of-care ultrasound for patients in rural remote regions. Took about 3 to 4 weeks to train each midwife, and there's another publication about that, all right? So we brought them into Nairobi, the midwives, and we put them with the ultrasonographers and the radiologists, so no boundaries about professions, just agreement that we're going to teach these midwives to do this part of doing ultrasound. We made a form that had 20 things they were going to measure. You know, the length of the baby, the size of the head in comparison to the things, the number of, the amount of light where it was seen. We taught them how to do this, how to do the scan and how to look at what they're doing. And a tick box, right? So if they had a cross in one box, if there was one thing that they detected was not right out of the 20, they would upload that and send it back down to the specialists in Nairobi to have a look at it and say there's a problem, there's not a problem. Okay, so the midwives they didn't take the role of the doctor and the interpreter. They needed to take the scan and look at those metrics. So then we had to look at a system of how to get the scans to be validated by the experts, identify the high-risk scenarios where mothers be renewed, and the training and program that we had to have it very rigorous with entry and exit testing with hands-on training and directly observed by a competent obstetrician and competent radiologist. Okay. So how we did the technology in terms of, we worked with Philips and the telco. So, you know, a telco is like, who does your mobile phone service? We had Telstra and Optus and Orange. Who's the, you know, there must be somebody that's your provider for your mobile phone that does the telephone towers. Yeah. So we called that the telco. So we worked with one of them, and we worked with Philips, you know, so Philips makes ultrasound machines and everything like that. Okay. Yeah. And we did a trial at 3 outreach centres, one at 10 kilometres, 120 and 400 kilometres from Nairobi. So we scanned the women at 10, 120 and 400, okay? In some cases, we scanned them in community centres and churches or even on the roadside, right? And we used a mobile phone and modem to do the thing. So here's the scanner, the little picture of it, right? So you can take this, you can plug it into a Jeep in the car. You know, the USB in the Jeep goes everywhere. You can plug it in. You've got the little screen. You can see you've got the bit that you can do the scanning with, right? You can then get the scan. We found that our average time of transmission, regardless of distance, whether we were 10 kilometres or 400, and we kept working with the telco, was 6 minutes to get it back to the hospital, okay? And the images and the provisional reports were sent back. So the midwife's out there, and she said, there's something, I think I've got twins, or I think that I've got a placenta previa, or I think I've got maybe, you know, like the dimensions for small for dates is not right, you know? She'd send it back. And then the specialists and the radiologists, after validating the file, our average time, because you have to ask the mum to wait, was 15 minutes.
Is not going to speak with a gynecologist as well.
Yeah, obstetrician, gynecologist, yeah. So they come down and have a look, 15 minutes to validate. Yeah, okay. Yeah. And then any concerns or discrepancy logged and returned to the midwife. So if the midwife came back and said, you know, you think you've got this, but it's this, and the reports were printed at the centre for the local health centre. So at the end of the day, it was a highly successful interprofessional initiative. It was basically where what we did task sharing. We shared some of the tasks of a radiologist and an oncologist. We shared it with midwives, because midwives, like there's not many ultrasonographers in rural Africa. So you can't say, well, only an ultrasonographer can do that. You actually said, here is the solution. What about this specialty practice can we teach to this specialty practice? And the image transition was faultless and cheap. Mobile phone services are an effective tool in transmitting the data. And that then we actually, so what we did then was that for every woman that was scanned, the ultimate test of accuracy is to wait until the woman delivers and tell you whether it's right or not, because that's the proof, right? And we had greater than 99% accuracy. We only had 2 cases where it wasn't quite accurate, and the problems were 1 week out in the dates, estimates, a little bit about dates, right? But no abnormality was missed, no twins were missed, nothing was missed. So a highly, highly effective way. And then you can scale this up. You can teach midwives all over Africa to be sonographers. So and in the UK now, I see there is a qualification called midwife sonographers, is that you can actually get a qualification like that. But also this was the blending of technology that basically says, don't go out there and you have to build, you know, another ultrasound centre and install a machine. You can basically, with this cord, put it in a Jeep and go to wherever the woman is. Put it in a car, plug it in, off you go. Because quite often by the time the woman is in labour or the time, things like that, is that woman is responsible for looking after 5 or 6 other children, for feeding the family for the day. She can't keep travelling 50 kilometres to the nearest place to go do everything. So it was just, this is an example of what can be done when professions work together and actually are not precious about the boundaries. And this was also overseen and supported and signed off by the World Radiologist Association. So those are specialist doctors who become radiologists, and because they were the guardians of what we were doing was safe practice. Always the thing is, first do no harm. So yes, you can task here, but how do you work together and say, well, you could do that, but not that. So the midwives could do that, but we never said the midwives could determine or detect if there was an abnormality. That went back down to the specialists to have a look at.
Not just like brilliant example of telemedicine.
Yes,
More than
yes. So there's just some of the other things that I've been involved in that talk about the expanded roles of nurses and where healthcare and where delivery and scopes of practice and roles are going. So the next thing and the last little bit is about the other great thing is about telehealth and virtual care. So in America, they say that by 2030, 50% of all GP consults will be virtual, right? But the issue is this, like, so when you start as teaching a junior nurse or a junior doctor or things, one of the first things you teach them is how to undertake a physical health assessment. Take the vital signs, listen to the body, palpate, first, okay? The question is, how do you practice safely in virtual contexts? So if you're on the phone, you have one sense, you can hear.
Yeah.
If you're on a video, you have two senses, you can see and hear, but you can't touch, you can't. How do you safely undertake that and not make mistakes, right? So that's the question. So we've just published this last week, and you would have seen it's a work I've been doing for the last 6 months with Antonio. You'll see his name on there on Brownie. It's got Ava Masada on there. And that we've been looking at what are the clinical guidelines for virtual health assessment and care. We did a scoping review, right? And there needs to be much more work done in this field. I then had a little look for literature here in Italy, and it's slowly expanding in Italy. Yeah. Again, it's here. But opportunities exist for the University of Parma and its educators to consider how they'll teach virtual assessment and telehealth skills. It is a thing that is coming. So how are you going to prepare your students and nurses of the future to undertake telenursing and be safe? How do you do that? Okay. So one of the things we found is this thing, and this has been developed by doctors and it's been used by nurses a lot, is a telehealth framework for virtual care calls. So one of the things is about being systematic when you're on the call, and how do you do it and what can you do, and et cetera, et cetera. So the telehealth team framework to guide virtual care calls is worth having a look, and I've put the references there. And then there's these things. And these have been developed for geriatric care. So if somebody's gone home and you're making a call to see if they are all right, what is the systematic way that you would see if they're all right, and what would you cover off in the call, right? So basically the 4M's framework, it says what matters. So what matters means what is individually important to patient-centered care for that family, right? As to whether it's transportation or whether it's what matters. How they're going with their medication, right? How are they feeling psychologically, what their meditation, if they've gone home, they're depressed, they can't sleep, they go, no, I don't know, or whatever. Yes. Yes. First of all. Yes, yeah. And then the mobility. So it provides a structure of all the things that should be covered off in the call. And then the 5M's framework of geriatric care, Spanish doctors took 4 M's, and they added one more thing, right? And the one more thing that you've seen that they've added is the multi-complexity, which is usually if they've got chronic obstructive airway disease, they've often got blood pressure problems and edema and a whole lot of stuff going on, So those are some of the things that we're starting to think about. And these are just examples that I've given you today about how nursing practice is changing, and why it's changing, and why it's absolutely going to keep changing. And because of those global demographics, because of the increasing shortage of healthcare workers, and about having to be not precious, but really smart about the professions talking together and saying, your specialist skills are best here. You could do this, you could do this, and you could do this, and how can we work together? One final thing I'd talk about. So, for example, in Melbourne, there is a hospital called the Alfred. It is the largest trauma centre in Australia, right? And when you look at the statistics in terms of what comes into the ED department, you know, road accidents, workplace accidents, kiddie accidents, homes, heart attacks, and things like that, the single biggest thing is for mortality and morbidity, right, is falls in over 60s under 1 metre. Yes, yes. Falls in over. So again, we were working in our student-led clinic to run anti-falls programs. So we would have a nurse, a physiotherapist. So we would get, first of all, the nurse and the occupational therapist would go out to the home and do an inspection at home. Are the steps wobbly? Is there a rail? Is there a guard in the shower? Are the mats all loose? Are there cords across the room? So we would go and first of all help to remove the risks from home, right? Have you got a walking stick? Is your front path all cobbled? Is it even? Can we make it more even? So first of all, we do that. And then basically we had an 8-week program about exercise and balance.
When people they have a good condition to live in their home, how can we do? We have to transfer the patient in a different structure. Or?
Yeah, we have occupational therapists that allow. Yeah, and the people like it. And the GPs, then we send a report back to the GP and say the modifications that we have recommended. And we have something called an ACC, an Accident Compensation Commission, who pay a lot of money for when people fall down and break themselves and have hospitals and have hip replacements and never get quite, like, old people regain their mobility, but not totally, and sometimes not at all. So therefore, there are more drain on the system. So the best thing to do is try not to stop them falling down. So then when you've kind of sorted things at home and done education to make people more aware of how easy they can fall and why they would fall, and then special programs in terms of at-risk groups, because at-risk groups, for example, are diabetics. They have peripheral neuropathy. They don't feel their feet properly. Parkinson's disease, more likely to fall. So how you can put the protective in. And then the other thing is about an 8-week program, and the groups like coming together. It's a social outing as well around simple things that even, you know, from 50-year-old up you can do. So when you clean your teeth in the morning, right? Stand with your shoulders against the room, only stand on one leg and clean your teeth for the first bit, and then stand on the other leg and clean your teeth. These things that help balance, you know. So teaching people things like that, how to maintain their strength and how to maintain their balance.
Italy is quite different. I mean, after the admission, after the discharge of the patient, they can transfer to a typical structure, and they're not going to pay for 2 months. After that, they have to pay to stay for staying in the same structure, or they can transfer to I don't know, nursing or something like that.
Like a rehab hospital. Yeah. Wow. Yeah. No, we don't have we have rehabilitation wards, but you might be there from 1 to 10, occasionally 3 weeks, and there's fairly high criteria because to get there because it's very expensive. Most people go home with support from home. Yeah. So anyway, any questions? But those are some of the things that are happening in nursing practice, and some of the reasons that they're happening, and they will keep happening. Those changes, those trends will continue.
Sorry, we didn't catch that.
The trends towards more nurses with expanded scope, that will continue. Yeah, there will be more and more of that. Yeah. Yeah. So I have included in there some of the projects that I've been involved in and some more papers and things, and you can have a look at that.
I got a question.
Yes.
But it's related to the first part of your lesson. When you're talking about the students, you're talking about the clinical anecdotes, something like that. My question is, do you have you can suggest for us a specific tool to evaluate the experiences of students?
Okay.
Other tools.
Yeah. So there's lots of validated tools on lots of things. So around student-led clinics and interprofessional practice, right? I have 2 publications around tools that faculty, the staff, can use to assess the students' readiness for interprofessional practice. Because some students say, what do I have to do this for? I came here to be a nurse. I just want to know about nursing stuff, right? And so you can use that tool, and then you can, to assess their readiness for interprofessional practice, and then they can do a placement in an interprofessional clinic, and then you can assess afterwards, right? So I have a publication about that. I can send you the link. And then the other thing is, we did one that was then saying, if you want to look at interprofessional competencies and how you're going with your interprofessional competencies, what tools are there for students to assess themselves or assess their peers? We have a publication about that. We've published that recently as well. I can give you both of those. So there's definitely things that you can do that helps your students to start thinking about what they're doing. Yeah, and also that you can do them at the beginning of a course, at the end of the course, to see if their competencies or their attitudes have changed. Yeah.
You send me the
Yes. Yeah. Okay.
Thank you so much.